אז ערב טוב, ברוכים הבאים, ברוכות הבאות להרצאה השנייה בסדרת שלושת ההרצאות בנושא שינה בסיוטים IRT עם דוקטור בארי קראקוב. אנחנו נתחיל בעברית רק להציג את הנושא ומיד נעבור לאנגלית, כי ככה ההרצאות שלנו מתוכננות. ההרצאה היא שיתוף פעולה של החברה לבריאות הנפש בקהילה והמרכז לבריאות הנפש שלוותה. ההרצאות הן בחינם ומוקלטות ומועלות לדף הפייסבוק ולעמוד היוטיוב של החברה לבריאות הנפש בקהילה, ובעיקר תודה לדוקטור אביב סגב על היוזמה ועל הקישור לדוקטור בארי קראקוב. So, good evening everyone. Thanks again for joining us for the second session out of three webinars in the most important topic these days, sleep and sleep disorders related to trauma. And we have Dr. Barry Krakow with us. Just to present our lecturer, we are honored to have with us tonight, Dr. Krakow, who is an internal medicine physician and clinical sleep medicine specialist in practice and research for over 30 years. His focus on sleep in mental health led to multiple discoveries and to diagnose and treat sleep disorders. He lectures and writes widely on sleep and mental health and more than 100 peer-reviewed scientific publications, as well as 4 books, the most recent, Life-Saving Sleep, New Horizons in Mental Health Treatment. And I must say that your first lecture, Barry, was so wise and practical, and we learned so much from it. Today's discussion is nightmares and IRT, and the floor is yours. Thank you.
Thank you. I wanted to start with a couple of footnotes from our insomnia discussion, because I wanted to get across the fact that time monitoring behavior is another really important aspect of care, because as I said, it's the second most common symptom many insomniacs will say, that they are having racing thoughts, of course, can't turn off their mind, but they become fixated on the time. And we've written 2 papers on this. I think you can access both of these online. The first one actually showed that people with PTSD do more clock watching than other sleep disorders patients. The second one that we just published this year shows that time monitoring behavior seems to have a link to individuals either using sleep medications or worsening their insomnia such that they then want sleep medications. So it could be a very useful tool in terms of being able to decrease dependency on sleep aids if appropriate for the patient. Now, so I just want to get across that it's an incredible tool, but the second thing of speaking of time is we come back to this thing about acute versus chronic. And right now we're at the 3-month mark or so, or getting there. But just because we hit 3 months doesn't really mean that the patients you see are suddenly chronic. Many of them remain in an acute phase for whatever period of time. As we mentioned before, ongoing trauma, unending grief. And so time monitoring behavior is fascinating, because you will have people who absolutely reject this instruction. Monitoring the time is a crucial crutch that people use during this time that actually gives them a sense of security. So I'm just pointing it out. It's a good example of acute versus chronic. When things do become chronic, people are much more likely to listen to a discussion about time monitoring behavior and consider decreasing it to improve the problem of insomnia. Just wanted to get that out there. All right. So like last time, I wanted to mention, we start out again with a study. This was our study in JAMA, published 22 years ago, Imagery Rehearsal Therapy for Chronic Nightmares and Sexual Assault Survivors with Post-Traumatic Stress Disorder. And the question of the day back in the 1990s was that IRT could not possibly work on post-traumatic nightmares. For anyone unfamiliar with IRT, it is simplistically recording a nightmare, or nowadays we say selecting a nightmare, Recording is not so important except in certain cases. Changing the nightmare, and then rehearsing the new dream. It really is that simple. And if you had a patient of a certain type, you could explain it just like that, and you're finished. You've actually completed the therapy with some additional coaching. As you're going to see, what we talk about today is more about more severe cases and why we add more what I'll call, or what you would call too, I think, cognitive restructuring to actually deliver this therapy. So in this study that was published in JAMA, the reason it was published wasn't because of the phenomenal reduction in nightmares. There was people who had nightmares 3, 5, 7 times a week. And after 3 months, they were down to 1 or 2 nightmares a month. The reason the study was published was because the reduction in the nightmares led to this very large reduction in the black circles of the post-traumatic stress score. This is Edna Foa's PSS tool. And what's even more interesting about that is if you look at the total, by the way, can you hear my dogs barking or not? No, okay, good. So you see the total score there drops about 10 points. But now look at what happens next. Here is the 1990s DSM criteria of intrusion, avoidance, and arousal. You have intrusion scores dropping by about 40%, close to 50%. You have avoidance scores dropping by 40%, and you have arousal scores dropping by about 40%. So nightmare treatment actually looks like a PTSD treatment. It actually affects all aspects, and the question is, why? What could explain this? Is it simply when you decrease an intrusion symptom, you're obviously going to get less arousal. And if you get less arousal, there's a good chance you'll get less avoidance. That's a good theory. Another theory is if you get rid of the nightmares, your sleep is no longer fragmented. That means you have a chance for deeper, more consolidated sleep. And then another possibility is imagery. Imagery in many different forms has always been described in psychological and other literature as a kind of therapy. And it's possible the regular use of imagery leads to carryover therapeutic effects. I don't think we know why PTSD gets better other than some of these obvious explanations, but it's not as if this is something that's been proven. Nonetheless, it's certainly worth considering, and patients obviously report things like, hey, it's great that my nightmares have decreased, and it's great that I'm sleeping better. Now I'm going to send out I'm going to give you a little teaser question here that it turns out in our 3 groups that we discussed last time, the normal sleepers, people with no past issues of sleep, the middle group, troubled sleepers with good to excellent response to their previous sleep problems that now may be exacerbated. And then our 3rd group, we said, is the chronic people with very difficult sleep problems that never seem to have responded well. It's that group that's going to have a very special connection to the use of IRT. And I want you to think about that because we're going to come back to it and ask yourself, why would this group be especially suited to get IRT? And then again, the caveats at the bottom, trauma type and severity, and the problem of all of the death, the grieving, the burials, the mourning, and so forth that you all know far too well, painfully well. Okay, so we're going to start off with a paradox. And even though you might not see it this way right now, if you look at the vast overarching research on nightmares, it's been well described that the vast majority of those who experience trauma in nearly all age groups do not develop chronic nightmares and do not develop chronic PTSD. And that raises a very interesting theoretical question that may have very important clinical applications. Now, is it something like people cope better with distress, and so those people, that's why it gets better? Is it others who are very good at working through emotional distress? Is it people who have strong repression capacity? Are some people simply fortunate or blessed? There could be a lot of theories. I don't think anybody has come up with a great theory other than the time, of course, is the best physician. And so over time, people do heal. So in our work over the years, we ask, could the how, not the why do the nightmares get better, but could there be a how that actually explains this? And if so, we're wondering if this explanation might also explain why IRT operates the way it does. And that is, what if our mind's eye actually functions as its own self-healing mechanism? And that is, does the imagery in our mind's eye seek to heal? So this brings up a concept from what's called the dream research literature, which has been around for decades. It precedes the field of sleep medicine by many, many years. And in this example, I'm going to give you an individual who had a trauma and maybe never got therapy, or had a trauma and did get therapy and medications, but the bottom line was nothing seemed to work. So they showed up in a clinic of somebody who's called a dream therapist, and a very famous doctor, Dr. Deirdre Barrett, wrote a book called Trauma in Dreams, and she described this process. I'm going to walk you through this because this, I believe, explains possibly how the imagery system is working to self-heal, and it might even be the same theory that has to do with why IRT would work. So this individual walks in and says they've been traumatized, and they report a replay of that trauma. And we're going to discuss more about replay as we go on, but replay of a trauma is a very poor prognostic sign if it's something that continues to be a chronic state. That is almost always associated with somebody with more severe PTSD. So what happens in this first session with the dream therapist? Well, they describe the replay of the dream. Of course, they told the therapist about the trauma. They described the replay. The dream therapist says, all right, I want to talk to you not just about the content of this replay. I want to talk to you about what you were feeling, what emotions you felt in that dream. And from those emotions, we want to try to process that information, and we want to gain some insight. And at the end of the session, we want to see where things stand with this processing and with this insight. And so what happens is this patient does this through several sessions. And when they come back at some point, it could be the next session, could be 3 sessions later. Let's say that this person's trauma was they had been mugged in a parking lot, okay? And that was the replay of the experience. But now when they come to this later session, after having done just 1, 2, or 3 sessions with the dream therapist, now their dream is they're running on a beach trying to escape a tidal wave. And sometimes the tidal wave overcomes them, and sometimes they escape the tidal wave. But you can see how that would be symbolic of somebody undergoing an attack, but it's not the replay. And so they do the same thing. They go through, what were the emotions you felt during that experience? What can we process and what insights can we gain and learn? And they keep doing this in these sessions. And what happens eventually is the individual has what are called disturbing dreams, not so much a nightmare anymore. And they're usually non-symbolic. In this case, it could be the person would say, well, I remember something about being in darkness, and I remember being nervous and maybe a little bit scared, but that's all I remember about the dream. And as this process continues, again, dealing with the emotion, dealing with emotional processing, gaining insight, learning something, person eventually gets back to normal dreaming. Now, this theory has been around for a very long time. There's not many dream therapists in the world, but there are an abundance of them in different places because there's even something called the Association for the Study of Dreams, which has been around as long as the sleep societies have been around, if not longer, in terms of their research. So this is telling us, I believe, something very important about the way the mind's eye operates. And working with dream emotions leads to processing and information, which alters dream content. And I think this is probably part of what is the natural mechanism for why so many people would see a decrease. So how is the imagery system operating during the dream metamorphosis? So it appears the mind's eye in sleep experiences numerous images during which these images can change. So when you think about the daytime mind's eye, a similar pattern of flux is occurring. In other words, in your daytime, images come and go. So certainly they could come and go at night. And that means we would ask, could you actively picture daytime images, and would that create a potential for changes in nightmares? And to sum it up, if dream imagery constantly shifts and naturally changes content and emotions, perhaps active daytime imagery instruction influences this inborn, this inborn system to gain or regain its natural momentum toward recovery. Okay, so now we're going to do a little trial for everybody of IRT. These are the 3 steps, and I want to talk about the pioneers who started it. Dr. Robert Kellner escaped Czechoslovakia in the late 1930s and later reported that he lost all of his family to both Hitler and Stalin. He was a psychiatrist in New Mexico in the 1970s up to the time of his passing in 1992. And the first patient that got him on this journey was a young woman with panic disorder, PTSD, several other mental health conditions, having nightmares of being chased to the edge of a cliff. He gave her the instruction to change it, change the dream. She changed it to jumping off the cliff and dying. And a few weeks later, all of her nightmares were gone. This obviously got his interest. He published this in the Annals of Clinical Psychiatry. He then recruited Dr. Joseph Neidhart, who is another remarkable man who, at the age of 48, after a 20-plus year career in family medicine, decided that he wanted to enter into psychiatry. So he started a psychiatry residency program with Dr. Kellner at the University of New Mexico. But Dr. Neidhart also had this fascinating background of working with a world-famous dream researcher and clinician, Dr. Rolf Lurisch, in Vancouver, British Columbia. And so he was very familiar with dream interpretation theories and readily gravitated toward this whole program of IRT, and especially the concept of how you change the nightmare. So originally, we talked about you can record it or select it, write it down as a story. These were Dr. Neidhart's instructions in the first study where they compared IRT to desensitization. Change the nightmare any way you wish. We'll talk more about that, but that's literally what it means. Change it any way you wish. Again, create a story if you like. And then you rehearse the new dream. And then you would say this to the patient. So we're going to do that now. We're going to spend a few minutes, whether you've had a nightmare or bad dream recently or not, you've had one in the past or not. What I want you to do is please recall something, some content that you could use as the bad dream that you're going to work with. So I'll give you a few seconds on that one. Okay. Now this is the one where you can spend more time if you want, or maybe it'll take you no time at all. I want you to change the nightmare, change the bad dream any way you wish. No further instructions. Change it any way you wish. So let me give you a few seconds on that one. Okay, and for those of you that are comfortable, I would like you to close your eyes, take 1 or 2 relaxing breaths, and then in your mind's eye, just spend a minute or so picturing the images of the new dream you've just created. Okay, open your eyes, please. Take a deep breath. Now, let's see. If we can get a volunteer, and if we can't, it's okay. But if somebody wants to volunteer in the group to describe their experience, this is what we're looking for if somebody, again, wants to volunteer. To briefly summarize the content of the nightmare. That means literally, I had a nightmare about a phrase. That's it. We don't want to hear about a nightmare. We just want to hear about, this is what my nightmare might have been about. But now spend some time describing what you did to change it. Like, what was the new dream like? What was that content? It's fine to spend several sentences on that. But then most importantly, describe what was your experience like in trying to imagine this in your mind's eye. What happened with your imagery? So I'll leave it to Ido to tell us if anybody wants to volunteer. And we would like to see your face if you're going to volunteer so we can hear you speaking more clearly, if that's okay.
Yes, so Levi Smith would like to talk. Levi?
I'm happy to share if no one else wants to.
Sure. Where's the screen? I would like to be able to.
Can you see
Okay,
me?
well, that's okay. Just go ahead and start talking. That's fine.
Okay, it's actually a real dream that I had last night. So it was easy for me to connect to it. I had a dream that I was driving somewhere and I stopped at some, looked like car wash or store. I don't remember what it was. And somehow someone from the outside was able to quickly steal my wallet and drive off with my car, leaving me all alone and feeling really hopeless. And for the rest of the dream, I was just trying to get back my car and my my wallet and all my ID.
Okay.
That was the nightmare, the bad dream. Then I changed the dream so that I never left the car and I never opened the door. And when I thought about it more in terms of the imagery, um, I pictured myself getting close to where that person was and a feeling of tension coming up and telling myself, even though I see this person, I know that he's probably going to ask me to leave the car. I'm not leaving the car. I'm not opening the window. And then a feeling of more security, safety.
Fantastic. It's almost as if I've paid this young man to do this, but I promise you, that didn't happen. This is such a perfect example of what I wanted to get across here. So this is excellent. Thank you so much. It's Levy, is that what you said?
Yeah.
Okay, thanks again. So what happens is the concept of changing it any way you wish, we'll talk about again more at length, but I want you to notice that the individual changed this in a way where it was still close to what had happened. And it even got to the point where he said, and there's some tension that I noticed. In other words, most people, when they hear this instruction, and I'm not saying this because this is the right or wrong way, I'm just saying this is the most common way people make changes, which is a sense of mastery, that they're still in a similar situation, but they're changing it around, they're taking control over it, and yet they're still placing themselves into what looks like an at-risk situation. So that was an excellent example. And what we're going to talk about now is that when Dr. Neidhart focused in on this instruction, especially from his background in dreams, this was a psychodynamic model from his understanding. By asking the patient, the individual, to make the decision about the change, that was probably going to be the right change. Some people have to hear this as, what does that mean, change the nightmare? Say, well, you're going to make a new dream. You go, okay, I think I understand. And they go, what about the old nightmare? And you go, well, no, we're not dealing with the old nightmare. And then, of course, that sounds like a psychological ploy. And I'm not saying it isn't, but it wasn't designed that way. It's obviously, if you tell somebody to ignore the old nightmare, some people might say, I can't. That's already telling you maybe they're not a great candidate for IRT. But their goal of it really is not about desensitization of an old nightmare. That's very important to hear. This is not a desensitization technique. It's not an exposure technique. Back in the 1990s and 2000s, there were many researchers who were very much trauma specialists, PTSD specialists, and they insisted this had to be exposure therapy. And, you know, we did another study showing them that we asked people, like, you know, mark down how much time you spent on your old nightmare, because the instruction is don't. And, you know, virtually everybody who did the treatment said, no, I spent no time with the old nightmare. They're only working on the new dream. Now, you could argue, well, what if there's so many elements in the nightmare, in the new dream that might be like the nightmare, just as, you know, Levy just did in his example? Is it possible that's some exposure? And I have to admit that it is. So there's some question about this, and it's still undecided. And you'll see as we discuss the concept of combining exposure and IRT, why this is important. When people do IRT, they will usually see a change in 2 weeks. That change is usually a decrease in frequency. Sometimes it's a decrease in intensity, but there's just a change. Some sort of change seems to occur within 2 weeks. But remarkably, the largest improvement they're going to get, like if they're going to get a 50% drop off of their nightmares or an 80% drop off, most of that occurs by 2 months. So there's huge changes occurring here in a very short period of time. Something that the patients with chronic nightmares of a large number, large frequency, think that they're supposed to work on every nightmare. Once they hear this instruction, they go, oh, I get it. So I have to do this on every nightmare. They actually think that. And if you think back to the sort of plasticity model at the beginning of this discussion of dream metamorphosis and how things operate, we learned that we tell people you can just work on 1 or 2 bad dreams a week. That's it. We've had people work on one nightmare for months. They'll take a nightmare, they'll change it, they'll have some success with it. And they go, no, I'm enjoying working on this set of images. I'm going to change it again. And that's what would happen. So that certainly makes it more appealing than saying, you know, work on each and every one. Now, I asked you at the top, why might IRT be especially suited to our category 3 patients who have been unable to resolve their sleep problems? And the answer is, amongst this group, you're going to find a lot of chronic nightmare patients. Well, chronic nightmares respond in terms of resonating with this idea of IRT much better than somebody with acute nightmares. And so if the category 3 patients are coming in with an exacerbation of their nightmares, you actually get to say, well, you've had this nightmare problem, it looks like, for 5 years or 10 years, and you tried a drug or you've tried psychotherapy. You know, we're not going to work on these acute new nightmares. They're too fresh. They may be reminding you too much of current events, and that's not really where we want to go with it. Let's look at your old nightmares. And the person might go, oh, well, I never even thought about that. Is that going to be a good thing? So, well, what if we can do something to decrease the old nightmares? And it's quite possible if you do that, it will have an impact on the more recent nightmares as well. And so that's why they're well suited. And that's an interesting option for these people who obviously suffer more than most because their sleep problems have never really resolved well. Now, let me give you another question that will come up a little bit later that I want you to think about. Would you use IRT on replay nightmares in this acute setting that we're dealing with now? If someone's nightmares are replays of a trauma that occurred less than 3 months ago, how would they react to an instruction, change the nightmare any way you wish? So let's come back to that question, but I want you to think about that. Okay, so now what we're going to deal with is, how do you introduce IRT to your patients? And again, this model is about people who have the most severe nightmares. That means as you go through this, you're going to say, well, I may not need that piece, or no, I really need that piece. And that's what I want to teach you, that all of these pieces are quite useful in dealing with the most severe cases, but they may not be needed for every case you would deal with. The first thing that we did back in the 1990s in working on IRT is to try to move the patients away from the idea that nightmares could only be related to PTSD, trauma, and so forth. But let me make a very special point about the 1990s for those of you maybe who were a lot younger then. At that time, people in psychiatry, in psychology, other mental health areas, believed that all sleep problems were the result of the primary psychiatric disorder. The DSM is described it just like that. There's no such thing as, quote unquote, an independent sleep disorder. There might be a hint of that. Ironically, later on, like DSM-4-TR and DSM-5 has remarkable coverage of sleep disorders as potentially independent. That information is not disseminated into either the field of psychology or psychiatry at any level of regular use. So back in the 1990s, if you tried to publish something suggesting that if you treated a sleep disorder, anxiety, depression, PTSD, etc., would get better, people would be like, what are you writing about? Where is this coming from? Dr. Kellner, Dr. Neidhart, and I published one of, possibly the first, article comparing IRT to desensitization in the treatment of chronic nightmares, after which their depression, anxiety, somatization scores, hostility scores all improved. That was published in the American Journal of Psychiatry. Not many people believed it. And throughout the 90s, more people published on nightmare treatment. Even when we published that article in JAMA, which is showing, well, you treat nightmares and PTSD gets better. Even then, it took the 2000s and now only the last decade are a small minority of clinicians and researchers embracing the idea you actually get this benefit. It's common sense to who? The patients. The patients have been telling us this for decades. Doctor, can you fix my sleep? I know it will help my mental health. But when you start with nightmares back in the 1990s with a group of people who've been in therapy for 5, 10, 15 years, who've been on psychotropic medicines for years, and they walk in the door and you say to them, well, we're not going to discuss traumatic events. We're not going to discuss the content of traumatic dreams. And the group of, in this the study that we did, the group of women who are there, they're looking around at each other like, what? I thought you said you're going to help us with our nightmares. And I said, well, we are. This is not psychotherapy. This is a different kind of approach, and it's based on the idea of a nightmare as a sleep disorder. So I am perseverating on this because back then, and even to this day, sometimes you have to get this point across that the nightmares can be separated from the trauma. And we'll talk more about how you do that. And these are the first 3 cognitive restructuring steps that we take. And each one of these is geared towards getting people to think nightmares as an independent sleep disorder. I'm fine with somebody saying an independent mental health disorder. That's fine. Either term is fine. But the point is, we're trying to make that connection that it's about sleep, because that means we're going to do something about sleep and make sleep get better. So, surprisingly or not, most people with nightmares think really bad thoughts about themselves if they have them chronically. They think they must be crazy. They think there is something very problematic with them that they would have this condition. And then, of course, when they go into therapy, somebody says, well, you may have PTSD or you may have this emotional conflict. And all those things can be true. But we say to them, but what's the nightmare doing to your sleep? It's making it have fear of going to sleep, awakening to disrupted sleep, anxiety about returning to sleep, unpleasant, disturbing emotions during sleep, fitful, restless, fragmented sleep. And then the insult to injury, you have to relive, in the worst cases, you relive these images and emotions while you're awake. Most people that, I'm a sleep doctor, so I have a lot of bias here, but from my research and my reading, I do not know how many psychiatrists and psychologists and mental health professionals know that up to 1/3 of people who are alcoholics, 1/3 started drinking because they couldn't go to sleep or they wanted to suppress nightmares. This is in the scientific literature. It's been around for almost 30 years, if not longer. So it's a very big deal that sleep has this much influence, and it truly is a nightmare misery index. The next thing we do is we go into the timeline. And this will be hugely important now and over the next 3 months, because you will be seeing patients develop chronic cases. You'll be seeing people prolonging the acute phase, unfortunately. But think about our experience in the 1990s. These chronic cases, they didn't think about the acute phase anymore. They don't even remember the acute phase. They just remember they were traumatized. And we want them to hear that there really are 2 phases. Why is that? Well, because of what we said at the outset. Most nightmares should actually go away with time. And so since they didn't, we want to figure out why they didn't go away or how they didn't go away so we can do something about them. So that brought up the next area that was hugely controversial and paradoxical for the patients. And again, they'd hear the question, well, in that acute phase, in those first 3 months, let's say, or the first month, can you think of anything that could have been a benefit to you for having the nightmares? And we didn't put this list up. This is the list that every single group we ever work with, they came up with all these things. At first, they looked at it like, they looked at it quizzically, like, benefits? What are you talking about? But I said, well, is it possible that the mind and the body have a reason for doing this? And they would go through this and they would say all of these things. You don't want to remember historical events in gory detail, but you do want to remember that this is your personal history. This is what happened to you. Nightmaring is a form of desensitization. Nightmaring can produce emotional expression and emotional processing. Nightmares are a good warning mechanism to prevent future trauma. And of course, nightmares remind you that you survived these awful events. And so people learned this, and this was a very interesting way that we often ended the first session of treatment. In the second session of treatment, this next section, and I'm only showing you a few slides, this whole discussion could take well over an hour, sometimes 2 hours. The whole idea of, well, we know the trauma produced the nightmare. There's no way that the nightmares couldn't have come from the trauma. That's exactly where they came from. And so the question, excuse me. The question is, what's the possibility that something goes on in the brain that makes the nightmare stay there, get stuck there, as if it's a learned behavior or a habit? And this, of course, was a very daunting discussion. And again, controversial, paradoxical. And in a group environment, there would be people who would be adamant that, like, this is crazy. There's no way my nightmares are a learned behavior. And yet there'd be other people who'd look and say, you know, it's funny, but, and I'll use a term here that I don't know if people remember from way back when, it's called a broken record. So there might be some people who are not old enough to know what a broken record is. And they go, is this like a broken record, a needle skipping on the turntable? Is that what's been going on in my brain all this time? Though people without any prompting will say that to us. And we say, yes, that's what we're wondering. Could there be a learned behavior component? And this is the idea of, nightmares could be trauma-induced and habit-sustained. And again, going back to what I said earlier, does every patient need to hear this? Not necessarily. But many patients need to hear this kind of discussion, because then IRT is not some overly simplistic, gee, that sounds like magic, I don't want to do it. I want to know why you think this is going to work, and you're giving them information. There's 3 more that we do that I'm not going to spend the time on here, but I just want to mention them because from your background in the world of psychiatry and psychology, you're going to be familiar with these ideas that some people do become attached to their nightmares. It's almost like a nightmare sufferer identity that creates a different model of care sometimes. Linking the imagery system to dreams is fairly straightforward, helping people recognize that, if you picture things during the daytime, as we said at the outset, maybe it can have an impact on your imagery system at night. And then, like any therapy, the readiness and capacity to apply IRT. There will be patients not suited to it. And this will come up especially when we talk about replay. All right. So now I'm going to go over several common questions that come up from the patients once they've tried IRT. They will say things like, well, my dreams are the same content, images. What if my change doesn't work? So in this situation, you would probe the patient and say, well, tell me about the content that you have selected. Also try to figure out what they mean by repetitive, because repetitive sometimes is close to replay. And you want to find out if it is repetitive but not a replay, because repetitive dreams are something that certainly can respond to IRT. Replay dreams, we're not so sure about, and we'll talk about that later. And you can always help a person when you listen to what they talk about, that maybe their dreams really are changing with very minor or subtle aspects. And that's a very good sign that it's moving in this direction that we talked about at the beginning, dream metamorphosis. People who have multiple different nightmares will often say to you, well, don't I have to work on each and every one? And this gets back to the same concept of no, you do not. IRT seems to be working as a global treatment of the imagery system. 1 or 2 nightmares a week has this ripple effect as far as we can tell. People are anxious about their nightmares. We tell them to skip the step. We've actually had people, excuse me, who do not do a nightmare. They just go directly to a new dream. They hear the instruction, they go, I get it. I'm just going to go to the new dream steps. Fine, do it. And they have been very successful. Same concept of a vague nightmare, same thing. Just create a new dream. Okay. So this is the biggest one, because this is a big controversy in the field of nightmare treatment. I don't know that it has to be a controversy, but it's certainly a divide. And that is that there's really not a right or wrong way to change the nightmare. A person could change one thing, that's it. A person could change the whole thing, that's it. The person could change the color of the sky is now different than what it was. Anything is on the table. And it's not, according to Dr. Neidhart's model of, change the nightmare any way you wish, it's not up for us as a therapist to decide that or even suggest it. Obviously, if there's no improvement, you could say to the individual, well, let's maybe try changing it again. But asking for help in making changes may or may not be as useful as it would appear on the surface. And that gets into this controversy that we'll come to in a minute as it relates to IRT and exposure therapy. For anybody who is stuck with poor imagery skill or is overwhelmed by imagery problems like daymares, flashbacks, traumatic memories, where they may not even be a good candidate for IRT, if you just want them working on their imagery system for other reasons. Remember, imagery is a good way to help a person fall asleep. So we have often said to a patient in this situation, don't use IRT. You're not ready for IRT. We want you to spend time working on your imagery system, getting more comfortable with it, and coming back to us and telling us that you now feel like you'd like to engage in this fashion. These are very good tools to use in psychotherapy. All right, so now we're back to the chronic replay nightmare. As I said, almost very often associated with the most extreme cases. It's good to confirm that it's a replay. Sometimes it's replay-like. Sometimes a person has a perception of it. Spotting small changes may create an opportunity for using RT. Most replay nightmare patients have such severe PTSD, I would normally think that you would want them to have exposure therapy. You'd want to do something to give them an element of desensitization that is going to allow them to get more comfortable, at least at some level, with other sorts of therapies and possibly IRT. But the attachment of the replay, is the same as the attachment to the trauma. So however that's going on in the patient's mind, it seems to me like it would be very difficult to give somebody this instruction. How could you tell somebody who just went through something October 7th or November 7th or December 7th, all the ongoing stuff? I mean, I would think this would be highly offensive to say to somebody, change it any way you wish. Now, this leads to the discussion about the variations of IRT, because that's the divide. There are trauma specialists who, once they learned about IRT, started trying to create models involving exposure therapy with IRT. And I'm not suggesting that's a bad thing. I'm saying that's great. That's another pathway that can work. It's not clear that it's a lot better than IRT. It's just not clear. But who knows? In the hands of a person who's very comfortable with exposure therapy, comfortable with IRT, I could see there being extended benefits. So I'm not in any way against it. I'm a sleep doctor, so I don't describe for you, the use of exposure therapy. But then there's another component of, in models of mental health care, would somebody think it's their responsibility to change the dream for the patient? Because if you go back into dream research and dream studies, they actually have a model where in group therapies, people make suggestions to other patients about their dreams, not IRT, just about dream interpretation. So that may be where this idea comes from. And there are people that use that model. I'm not convinced that it's necessarily beneficial or not. It may not be beneficial. And I've just mentioned some things here about why exposure therapy absolutely could be appropriate in certain hands. Same question, who should change the nightmare? And our model is let the patient create the new dream. And just a reminder that we're saying, if this is what's happening, then is it possible that imagery rehearsal therapy is simply inserting something into this process and moving it along where it initially had gotten stuck? Just a reminder that each of the three types is going to be at a different place with their disturbing dreams. Obviously, months from now, many of them who still have the nightmares become chronic and may prove to be more receptive. Will acute nightmare patients without replays be receptive? Possibly. Certainly, children may be the most receptive in the early going. But again, if it's a replay dream, I don't know whether that's appropriate. Okay, some contraindications. IRT should not, and I don't believe works on sleep terrors. Sleep terrors are a physiological change in sleep, usually occurring from deep sleep. There's no reason to believe an IRT would work on that. Very few people remember any content about their sleep terrors. REM behavior disorder is a very important condition that I'll talk a little bit more about, I think, in the next slide. But it's also a physiological disorder. There's not any reason to believe that it would respond to IRT, although somebody just got a big grant and they're going to be studying the use of IRT or other treatments in a REM behavior disorder. This is the disorder where you act out your dreams and you can injure yourself or others. Mental illness with psychotic features, PTSD patients with unstable imagery, I would be reluctant to suggest they try IRT. There's a researcher who claims that she's used IRT in stable schizophrenics, but it's never been published. And again, I'm reluctant to use it on extremely severe nightmare patients, at least in an early process. So parasomnias, sometimes called things that go bump in the night, sleep talking, sleepwalking, nocturnal seizures, acting out dreams, sleep eating disorders, sleep driving. You may have heard about all of these things in different ways. For example, you might have heard about people being on Ambien and having a very, pronounced parasomnia and actually going out and driving a car. But what we're concerned about is that in PTSD, for a lot of reasons, some of which we'll talk about next week, when the physiology gets this fragmented, many people will start engaging, in some of these behaviors, sleep talking, sleepwalking, and so on. The good news is most of them will not injure themselves with these behaviors. But anybody who does show a risk for injury, like having fallen out of a bed or hit somebody else who is in the bed or injured themselves just by knocking an arm against something, that's an absolute indication they have to have a sleep evaluation. Some of the time, you'll learn this happened because of the medication they're on. Some of the time, this happened because the PTSD is literally getting them so agitated during the night. And sometimes this happens because there's other physiological changes that they're susceptible to that nobody realized until this point. Okay, finishing up, I'm going to leave you with two questions because this will also help us segue to next week. I want you to think about the awakening process of somebody who had a nightmare. If you were watching a person have a nightmare or the person who was having the nightmare and then they were talking to you directly after. What were they experiencing? What behaviors, what symptoms, what signs, what would you be seeing at that moment? It's a very useful question because we want to know what the quality of their sleep was like before they had that nightmare, before they awakened from that nightmare. So those are the two questions, and we'll pick up again on that next week. And now we can go to Q&A. Thank you.
Thank you again for a very interesting talk and very practical and so wise. And it seems that you have so much experience in this field. And thank you, Levi, again for sharing with us your dream. There are many questions in the chat and the Q&A, but first maybe a clarification question.
Please.
People asked if you can define better the difference between replay dream and a nightmare.
Absolutely. That's a great starting point. A replay dream should be perceived just as it sounds. The individual says, I had this traumatic experience. This awful thing happened to me. They describe it. You're talking to them in a therapy session. They say, this is what happened to me. And they go, that's what I dreamed. I dreamed that same event. Now, it's true that if you, and I'm not saying to do this, but this has been done by research and in a very delicate way, you can probe that person and they will discover there's little things in there that are not really a replay. And there's a time and a place for that. But in the early going, not necessarily, because there is an attachment to that replay. This is what happened to me. I'm telling you, I'm dreaming about exactly what happened to me. And it's awful. I'm reliving it.
Mm-hmm.
And it's just a horrible thing. And you'd love to be able to say, okay, well, let's use some IRT so we can get that thing moving along so it's not a replay, because I know that that's going to help you so much. But I don't know that you can go there. That's asking a lot for somebody to go, well, wait, that's what happened to me. How can you ask me to change that? So that's what a replay is. And remember, there are people you will meet who absolutely will say something where you're going to immediately know that's more replay-like. You don't have to say that to the patient, but in your brain, you're going, oh yeah, that's not exactly a replay. That's replay-like. Okay, well, maybe that'll be a good tool we can use later on as we continue down this pathway. Maybe eventually I can plant that seed. Maybe this patient will begin to see these little changes.
Right. And maybe in this line of questions, another maybe related question, if this is a recurring, the difference between a recurring dream and a nightmare, would you say that it's the affect related, the emotional effect on the patient?
There's something about recurring, repetitive, repeating, these terms. These refer to people, generally speaking, who are describing a set of dreams or dreams that are, fairly similar in themes, such that when dream therapists work with these individuals, in some ways, it's a little bit easier because the dreams are repeating much of the same content, emotions, and that means some of the insights can come from that. If you want to go down the dream research pathway, the dream therapy pathway. But the fact that it's recurring versus people who have multiple different, I can only say to you, we have not found a difference in how such people respond because we're still only telling them work on 1 dream a week, work on 2 dreams a week. And that's an interesting point in itself, that when a person works on a dream, they can have some bad dreams for the next 3 nights, but you could say to them, well, just ignore those. You don't have to work on those. You pick the one on Monday, just work on that till Thursday. If you have another bad dream on Thursday, sure, you can switch to Thursday dream. It's all about working on the imagery system is what you're trying to get across, right, and not necessarily the nightmare.
This is exactly the next question, and maybe if you can just stop sharing the slide so we can see each other.
Oh, I'm sorry. Sure.
And the question is, should IRT be done on 1 or 2 nightmares or several nightmares, or how would you grade working on each night?
Right. So in general, what I found to be the most practical is when you have a discussion in a therapy session with somebody and they start talking about their nightmares. It's a good idea to always say, well, do you have this kind of bad dream, or tell me a little bit more about that one. Try to get a feel for the fact that they might be aware that they have some different kinds of dreams. And you would like to look at the dream that is the least distressing,
right,
with the least emotional content, least emotional intensity to it. Why? And you say this to the patient. And by the way, you're gonna learn this right now, but patients won't listen. And these are the replay nightmare patients. And this is why it's so very difficult in that situation. You want to say, we just want you to learn this system. I want to see that you can do this and you're comfortable with it. So, okay, tell me about that dream again. Okay, very good. Now, would you change that? All right. Now go ahead and, I'm going to, in fact, by the way, many times to make them feel even safer, I say, I want you to sit here for 5 minutes, rehearse the dream. I'm going to step out of the office. I'm going to close the door. You're here by yourself. You can do this on your, unless you want me to be here. But, you do this. I want you to feel completely safe. And that's it. And so then you come back, you talk about it, I say, well, what was that experience like? And I say, well, gee, that sounds like like you did all the steps right. That's all we're doing today. I really want you to practice this at home. Take this same dream. Just practice this one again for 3 days. Practice this one again for a week if you want. I want you to feel very comfortable with this system. And then you might even plant the seed like, oh, by the way, you remember how you told me about that change today? Well, don't be surprised if by Tuesday, when you're rehearsing your new dream, it actually seems to change some more, because that's the nature of imagery. That's the nature of dreams. And so when you're practicing your waking new dream and it keeps changing, that's a very good sign. That shows your imagery system is trying to help you heal. So always, if you can, but when you meet certain individuals, and these might be the people I call the nightmare sufferer identity, and it's very paradoxical. It doesn't make any sense to me. There are people where they will be given explicit instructions. Okay, we do not recommend IRT on replay like nightmares. We would like to go for some other disturbing dreams first, like I said, for all the reasons. I'll actually have patients come back to me and say, well, IRT didn't work. Like, okay, well, tell me what you did. I said, well, I took the replay like nightmare of my trauma. I said, well, do you remember my discussion about that's not such a good idea? He said, well, I wanted to see if it worked. So I tried that. Again, that's another reason why I've learned to be gun shy, because I've had, some, not many, but some experiences like that. So I really like to get people onto a track of, can you learn this skill? And let me say it for this reason. The people who learn this skill well and really embrace it, 90% of them or greater see noticeable reductions in nightmares. That's how powerful it is. And many of them, it's total mental. They wake up either in the middle of the night or in the morning. They go, oh yeah, I remember the bad dream. Okay, great. Oh, I got to change. And they go 15 seconds. Okay, I'm good. That's it. And these people apply the technique just like that because they've been doing it, more regularly than that to begin with. But once they did, they said, no, I understand. This is my mind. I have an ability to influence the images in my mind, and therefore I can do the technique just like that, and it's working. And we've seen this over and over again.
Yes, I think this has answered basically the other question that was, what if the new dream is, the content is even more devastating than the first one, or negative content?
You mean
So,
if the person chose, you mean the person chose to create a worse?
yeah, or if
Right.
it happened like that.
Well, what was the dream of the lady who said, okay, instead of like facing my tormentors at the edge of the cliff, I'm going to jump off and die?
Right.
Like, does that mean she felt closure and like that was good? Or was it terrifying that she said, I'm dying? So I don't think we know the answer other than 2 points. One is most people do what Levy did. I owe Levy a copy of my book. I mean, that was just like, I really didn't pay him. I got to pay him something. I got to get him a copy of my book. So the thing is, people do embrace mastery. It's natural. They want to take some control, and that's how they do it. But there's plenty of people who've done this, and you hear some of the things they tell you, and you go, gosh, really? Is that? And people do that, and they say that's what they wanted to change it. That's what came to their mind. And some of those people will see improvement in their nightmares. Does that mean that's the best way? Maybe it was for them. Maybe they had to start that way. So many people have, this is not exactly survivor guilt, but it's akin to that phenomena of like, well, how can I really change my nightmares? I mean, aren't my nightmares trying to tell me something? Aren't the nightmares about these bad things that happened to me? Don't I have to show some respect to the nightmare? And so I can change it, but maybe I'm going to change it just a little bit. That is such a common perspective that you can see and hear from the individuals talking about this process.
And is it a recommendation for a specific set the time for working, the mental work, the processing every day, I don't know, according to your research, your experience?
Right. I love this question because we always get this question, and it's really about routine building. So, for example, we actually used to tell people, don't do this at bedtime. But I don't know if you'll guess. I don't know if you'll guess why we said it. Does anybody want to guess why we said don't do it at bedtime? I'd love to hear if anybody has a guess.
So that they actually do it at bedtime.
Yeah, I'm saying we'd recommend don't do this IRT exercise at bedtime.
Right. So I think the reason you're telling them that is so that they do it.
I'm sorry. Paradoxical. Right. Yeah, paradoxical intention. No, we're serious. We really don't want them to do it at bedtime. This is what we said initially, but for a different reason. Anybody? I'll give one more guess.
Maybe because of the frozen mattress issue. People who can't fall asleep, and then they, I don't know, go that pathway.
You're very close. It's that once we saw, and we actually learned this from our first collection of nightmare patients, they go, this imagery stuff is amazing. I get into bed and I do the imagery and I fall right to sleep. And I go, well, wait a second. You didn't have any time to do the work on the new dream. Yeah, that's okay. But I just really like falling asleep. So we actually found some patients like that. And we said, well, maybe you shouldn't do it at bedtime, because how are you going to actually practice the part that we think is important? And we never got enough data to know whether those people who reported that phenomena where it's a problem. Like, yeah, they went to sleep, but then they had more nightmares because they didn't do the treatment. Really, it's any time. Some people like to do it in the middle of the night. Once they get more comfortable with it, absolutely do they do it. And they love doing it in the middle of the night for the reason that they've now got mastery, then they've got imagery on their side, and they can go back to sleep. What could be more delightful than having a horrible nightmare and yet being able to take control of it and then go back to sleep instead of being awake and pacing on the floor for 2 hours? A lot of people do it. Many nightmare patients, you may know this, often end up with a lot of bad dreams that don't awaken them. Over time, especially with chronicity, the nightmares, for some reason, they become desensitized to the awakening portion, but first thing in the morning, they remember the bad dream. So I say, oh, perfect time, do it then. Other people don't really want to deal with it around the sleep period. They say, I have allotted this during my lunch hour, At the end of lunch, I've got 5 minutes and I do it then. So really, it's any time that builds a routine. That's the most important thing as far as I know. Build the routine. And I said it before, I believe. We found that in one study, not this one, but another study, when we actually gauged it, people averaged IRT every other day for 3 months, and they average somewhere close to 1 to 2 minutes of use. There's people who did it, by the way, for 15 to 20 minutes. And there's other people who did it for 30 seconds.
Right. Aviv, I believe you have a few questions.
I wanted to condense a few questions that we've got into one. How soon would IRT be valid? Let's take out of the question the replay dream.
Right.
Let's assume it's not. And I would break it down to a few more details. What if the dreams are that different from one another? You have this sense of horror from every dream, but they're very different from one another. Right. You don't have 2 or 3 recurring dreams. And that takes me to another part of the question is how soon, let's think of the dream as a plot. How soon would you ask the patient to intervene with the plot? As soon as possible, to let it evolve a bit?
Right.
Would be the most effective way.
Right. So when I did these workshops, when I did workshops on 10 military bases, and I actually did one in Israel in 2011 as well. But these military professionals in 2013-14 had been exposed to a tremendous influx of PTSD because of the Iraq War, and they were clamoring for help for nightmare treatment, and that's why they called on me to do these workshops. It turned out, even though I did the workshops and trained many people, several hundred over time, some of them had already been doing IRT. These are like advanced scar therapists who had already been reading all the research, saying, I can do this, and they started doing it. I asked them the question because they would be much more knowledgeable about, well, what would you do in this situation? And I was stunned. Some of these people said to me they would use IRT within 1 week of trauma. Now, there was a disagreement about replay, or I'm sorry, there was more of a controversy, but what you're talking about is dreams that are not replays. We're taking that off the table for now. For anybody who's having, symbolic dreams, disturbing dreams, recurring dreams, repetitive dreams, but not the replay, any other kind of nightmare, they said, absolutely. I would do IRT within 1 week. And I'd sit down with the patient. I'd say, dreams function in this certain way. Right now, if you see the benefit, you want to go interpret them, because by the way, that's a whole, you should have gotten that from the outset. There's a whole theory of dream interpretation. You'll actually meet people who say, well, no, I like interpreting my dreams. But eventually they get tired of it. Even Sigmund Freud got tired of it. And you go, all right, well, what do you want to do about it? And then they say, well, I'm willing to try this idea. So their answer was 1 week. Now, let's take the situation we're in right now. If you have people that are not having replay dreams, if the content is such that you're not asking them to, quote, change reality, because that's what the problem is with the replay dream. You're saying, I want you to go and change reality. No, that's crazy. But if somebody's giving you dreams that are symbolic, they're disturbing dreams, they're bad dreams, I don't have all the content, you're already 3 months out for some of these people. And some of them actually could hear, again, like if you look at the cognitive restructuring, you look at the cognitive restructuring steps I pointed out, you just have to go down those steps and say, oh, is this person resonating with what I'm telling them about, well, nightmares are really a sleep disorder, aren't they? Aren't they actually interfering with your sleep? Okay, well, do you still feel there's a value to these nightmares in any way? Is there some reason you want to keep them? You can go down all of those kinds of steps. And then you can say, well, by the way, this is how the majority of people seem to have their nightmares go away over time. It's actually in the scientific literature that most people's nightmares go away. So we can do nothing. Maybe they'll just go away. But there's also this newer idea that you can try this program called imagery rehearsal therapy, and your nightmares may go away faster. Would you like to consider it? So there's a lot of possibilities there. But as I said last time, personally tailored medicine, healthcare, personally tailored psychotherapy is the absolute wave of the future, and it is going to create, much greater results. Does that answer your question, Aviv?
Yes, definitely.
Okay.
Definitely. We have a question. Is there any written guidelines for IRT? Like the suggestion you've made not to do it in bed, or to try to start with the easiest dream, with the less horrifying dream. Is there any guideline?
Well, if there are, I'm not sure what the person is asking, if they mean like, did the American Academy of Sleep Medicine or the American Psychiatric Association publish guidelines? The American Academy of Sleep Medicine did. It's probably the only place that published an actual guideline you can read about. And what they did is they looked at, a whole bunch of studies and said, here's our guidelines. Here's what we came up with. There's about, I think I said at least 15 nightmare treatment research groups throughout the world. The largest collection are in the Netherlands and Germany. And that's absolutely the best place to follow. There's a guy named Jaap Lance in the Netherlands. Last name is Lancee. He's been doing the best research on IRT for the last several years and continues to do that. So he would be the one to follow new developments in IRT. But as far as other guidelines, I'm not sure that the stuff that I've given you has been researched, like, time of day, amount of time, other than, which you can read in somebody else's research paper.
So there's no like, let's say, IRT for Dummies manual or something like this, like the most basic rules.
Okay, well, I can be really self-serving now. Okay, right. My wife and I developed what I believe is the only adult manual for nightmare treatment. It's called Turning Nightmares into Dreams. It's on my website, BaryKrakowMD.com, and in it, it's got 20 lessons. It's a workbook. Each lesson is like 2 or 3 pages. It's kind of fill in the blanks, try to, probe certain ideas. And then each audio from me averages like 7 minutes. It's the most widely used tool that I know of to train people in IRT. So we initially made it thinking that nightmare patients would buy it, because it's very self-help oriented. It's very easy to use. But yet mostly it's psychotherapists that buy it because they want more instruction and more ideas on how to deliver IRT. That is a individually based model. The other thing, again, self-serving, on my website is an introduction to IRT, which is about 2.5 hours, that goes into a model that I used, like I did some today, in treating groups. And that could be very important. I'm not sure, what that, like a program is here, but group therapy for nightmare treatment is a very valuable way to get people involved in IRT, in my experience.
Terrific. Ariella is saying there is a translation into Hebrew of your guideline. Is that what you mean, Ariella?
Has somebody done that? No, I'm not aware of that.
Okay. We have another question.
I'm open to somebody telling me that they want to translate it.
Okay. So from Roy, what is the difference between using IRT when there is no evidence of trauma, isolated nightmare disorder, versus when there is an evidence for trauma in the patient's past?
Right. So I'm not sure I understand the question, but let me try to define the terms. There's a term out there called idiopathic nightmares. I personally, professionally, do not know if it really exists. I'm leaning more towards the idea it doesn't exist. There really is no such thing. And what it really is an individual who, if probed properly or effectively or in a diplomatic, gentle way, we would discover there's some emotional conflicts that predate their nightmares. Now, can there be somebody who absolutely refuses this? There's no such thing? Sure. And so it's not for me to say that they couldn't be idiopathic nightmares, but those people have been treated with IRT and it's been successful, if that was what the question was.
Maybe, Roy, if you're here. But any other comments, questions, remarks, requests? Because we're getting closer to 10 p.m. here in Israel. So just maybe to conclude, thank you very much. A lot of messages like that on the WhatsApp and in the chat. Again, it was amazing, and we're looking forward to next week. See you soon.
So just a quick plug on next week, so you're clear. Next week, and you might, I mean, we had, it looks like, about half of the group from what we had the first time. I think we had about 300 last time and about 150 or so this time. The next session, I promise you, is the most important session that I can give you. And the reason is that the next session actually will explain why that third group was unable to actually resolve their sleep problems. And since those are usually the most difficult patients to deal with on a psychological level, on a psychiatric level, and on a sleep level, I hope you can encourage, excuse me, hope you can encourage more people to attend, because those people are in such dire need of more comprehensive sleep assessment, evaluation, and treatment. And in our work, we were very fortunate that we learned there's other models of care to help them that sadly are not being used throughout most sleep centers in Israel, in the United States, all over. And that's very unfortunate. That's why I wrote the book, Life-Saving Sleep, because it describes all of these advanced models. And we'll be discussing that next week. So I hope you can tune in and that I will keep you awake for another 90 minutes.
Yeah, on the edge of our seats. And may we conclude only with this wish that 2024 would be just a little better year than 2023. So happy New Year.
How about a lot better?
A lot better. All right.
We'll take a lot.
So thank you again. People writing in the chat, fascinating. Thank you so much. It's really helpful. So I'll send you the messages later. So
good. Thank you,
Barry, again.
Thank you all. Have a good night and have a happy, healthy New Year.
You too.
Good night. Thank you.